My name is Michael Victoroff. I work at COPIC. I'm an old guy, and so that in my world value system, that creates a lot of experience. And I'm going to talk to you about experiences that I have had in discussing one of the major health problems that we've got in medicine today, which is provider burnout. And I'm going to zip through a lot of this fairly fast, but do put questions in the chat, and we'll have some time at the end. Okay, so let's see. Disclosures. I wish I had some conflicts of interest. Forget that. What's the problem here? What we're going to discuss. It's called burnout. That's really not a scientific word. There are definitions of it. Whoops. And I'm not going to go into them because it doesn't matter. It's one of those things where intuitively we kind of know what we mean when we say burnout. And in fact, I don't care what your burnout is. I care what mine is. Here's the deal. A lot of folks, even before COVID, please be aware that this, I was talking about this before COVID. So, and when I said this, when I talked about this topic in 2018, 2019, these were very daunting statistics. Lots of people are impacted by what they subjectively describe as discomfort in work. What it is meaning, the implication for the workforce is that fewer people are applying to medical school. We're looking at potential shortages of certain specialties. We're looking at early retirement. I'm the guy that does the talks about electronic health information. And every time I give one of those talks somewhere to a group of docs, at the end, a couple of docs come up to me and say, "Whoops, I've had it. I'm too old. I'm all of 50 years old, and I can't face this anymore. I think I'm going to quit." So I'm going to get into EHRs a little bit later. But again, still pre-COVID, we have some terrible statistics. Now here, look, way pre any of this, in 1967, before most of us ever went to medical school, there were a couple of psychologists that wrote a really interesting paper. And what they were trying to do, and you can look this thing up, it's fallen out of style a little bit, but it was a really intriguing theory back a few years ago. These guys gave a schedule of recent life experience to people. They said, well, what's happened in the last 2 years? And you checked off some traumatic and possibly stressful events. You may be able to see some of this on your screen. Don't squint too bad. Death of a spouse was ranked 100 points. And then other sorts of separations, divorce, marital discord, death of a family member, death of a child, death, loss of a job, and down we go to many, many other things, which they gave points to, and they spent a lot of time normalizing this. Then what they found was that if they correlated the number of points you got on this stress inventory, they were able to predict the chances of a physical illness, mental or physical. Look, this was very important in the psychosomatic literature because it had to do with an injury, a heart attack, an outbreak of an allergy, or depression, and so on. But even things like cataracts correlated with your score on this schedule of recent life experience. So let us now be thinking about that when we talk about ourselves and the people we work next to. There are a lot of effects of feeling bad at work. You go to work feeling bad and you don't perform as well. Everyone kind of knows this. You can make a list of the things that don't work really well for us when we feel rotten. And then we cope, and we cope in dysfunctional ways. Alcohol, tobacco, caffeine. That caffeine is one of the better ones. I cope that way myself. But also things that are actually misconduct. Here is the extreme. In general, and this is pre-COVID, remember, we had 400 physician suicides a year. This was a fairly stable number. That's 2 medical school classes. That's not good. That puts physicians, just physicians, there's also other healthcare providers too in this boat. That puts us in a very unfortunate position, right? We're in a high risk. There is another schedule of another survey you can take, and I advise you to look at this if you haven't. A Burnout Inventory. Again, this comes from the psychology profession. When you start answering questions like, I don't really care, I just can't get motivated, I've lost the idealism, the altruism I brought to the job, as a medical student, I don't feel like it's meaningful. You'll hear this sometimes from folks, and you can manage it to an extent. You can help even in groups by saying, don't worry, tomorrow will be better. But when it piles up, you get these 3 elements that we could call burnout, right? Here's another definition. And you can see what these elements are. Feelings of it just ain't worth it. And then, so what are the group and social effects? These things are all documented and quantifiable, right? We don't work as well. We don't work as fast, effectively. We're not safe. People around us don't like us. The patients don't experience us as being what we want to be. Turnover, right? Cost, yes, there's direct correlates with cost, conflict, depression, everything. Diverting narcotics, so all this kind of stuff can be traced to this disorder. And let us also remind the folks at the top who may not be feeling this in a direct emotional way themselves. At the very top level of the manager, we need to notice that even a couple of years ago, I don't know this year's cost, it was almost $1 million worth of money that you lose if a physician quit. And the cost of bringing in a new one is on top of that, right? There's a lot of recruiting costs. And so I like to think of myself as being this valuable. Don't make my life so miserable that I quit. And then, please, here we are in 2020, all of this has been ratcheted up to a new level. We ourselves all now more concerned about, this is like Doctors Without Borders. We live in a war zone now. We have personal risk, the risk of injuring or killing our family, financial loss. Doctors are feeling it like restaurants. And then there we see all around us, COVID's not the only thing going on. If you watch the news today, there is a high degree of moral excitement, and I don't mean excitement in a good way, around social injustice. And there is a strain on the empathy of docs working in COVID units. You will hear them mutter, and it's muttering because we're all professionals. We won't say this out loud, that it's becoming hard sometimes to muster up the empathy that we'd like to have to take care of people who are not really doing their part to take care of themselves. That's always been an issue. But during COVID, it turns out that it's a big issue. Why don't physicians, this is just a doctor thing, but fill in the blank here. This could be true for nurses, chiropractors, physical therapists, x-ray technicians, pharmacists. We're all kind of in this. Physicians are the poster children. And this is a list of things that you see on surveys. Many of them, and I talk to residents frequently, what do you think about going and seeking mental health counseling if you ever got into a problem? And a large number are hesitant because they're not sure about confidentiality, and they're not sure about reporting requirements, and they're also not sure whether the board, the licensing board, will view a contact with a behavioral health support system generously or critically. Then there's this, we laugh, the stereotyped physician personality, but there is something to be said. A lot of folks who go into the health professions have a very exaggerated sense of independence and personal responsibility, which translates to guilt whenever you're under stress. Solitary coping, right? Feeling of looking weak, the mentality of, holding your breath and gritting through. This is astonishing. One of these papers said that 37% of physicians see that the time when they're going to feel better and relaxed and happy is after their career is over. That doesn't speak well to the way they work, or, to being the partner who's working alongside next to them, right? Let us just pile on here for another little minute about the consequences of burnout. It does impair our performance. When you're working around someone who is feeling bad, you can see the effect on their precision, their thoughtfulness, their cognitive load-carrying capacity. And it's pretty well documented that we make more mistakes and we're more dangerous when we're not feeling our best. Well, this is perpetual, right? Even back in the old days when we were just all macho people who gut through and stay awake for 40 hours at a time, that had provable, demonstrable adverse effects on patient safety. This old sort of analogy, I haven't done this work myself, but I like to quote it. After 17 hours working continuously, your performance on a skills function test is about the same as if you had a 0.05 blood alcohol. That might get you arrested in some states. That this might mean that after a 24-hour shift, you should not be allowed to drive home. You should be arrested in the parking garage. There are other things that make this even worse, right? That would be a median, but fatigue is bad. Attention overload. Think of the interruptions that come when you're being interrupted while you're dealing with another interruption, while you were trying to remember something that you were trying to do before they interrupted you. And this is an impairing condition. We all know about so-called alarm fatigue. We sort of mock it. And yet, if you were an airline pilot or military air traffic controller or drone pilot, there would be people monitoring you to make sure that you didn't have too many alarms in front of you at a time because you can't manage them. This is just cognitive neuroscience 101. You can only deal with so many emergency alerts at a time. So, what is our life? What are we dealing with in this environment? What's the cause of burnout, right? And I'm going to say that there are actually two, and this sort of gets to the theme of what I'm going to talk about for the rest of this time, and that is that in most seminars, workshops, discussions that you're going to see or you have been already exposed to on the topic of burnout, there's a lot of emphasis on individual resilience and making you tougher. And I'm going to say that's nice as far as it goes, but that is the lesser of the remedies, individual resilience. Now, individual measures, this is the yoga and broccoli approach, right? They do have benefits to address what I call the intrinsic hazards of healthcare. You knew these things when you signed up to be a doctor. You might have known them when you were 6 years old. The intrinsic stresses that we deal with that come with the job. People die. People get sick. People are grouchy. A certain number of people are just miserable to be around or work with, and yet you're supposed to anyway. You get tired. Babies come at night. Who invented that? That's terribly inconvenient. And yes, interruptions are a part of the job, that you can't not be interrupted once there's an emergency. You signed up for this. And sustained periods of concentration. My goodness, we're talking in the era of COVID. These are things that go with the job. And if you don't have a certain amount of innate resilience, you can't do this, and you never would have made it through medical school, or you shouldn't have. But those are not the things really that tear us up. The much more influential stresses on the health workforce are what I call extrinsic hazards or systemic hazards. These are the things that are not intrinsic to the job. There's stuff either we bring in from outside or management systems create for us. And you can see kind of where I'm headed with this, right? Workload, managerial, administrative expectations, unskillful management. That is one of the primary reasons why people quit their job. Resource shortages makes it hard. Production pressure, oh goodness. Inequity, I'm going to stress this one. Moral discomfort, watching things in the workforce or even bringing them in from outside that are clearly unfair and unreasonable and unjust, create a sense of disturbance in the brain that is really hard to work around. And this should not be an intrinsic hazard of where we work. Helplessness. And then I'm going to, the one at the bottom, this is sort of the one, if you go to, business school and you do a survey of why do people in any profession, occupation quit? What makes people quit their job? And it's a bad boss. You have a terrible boss. That would be the first reason to leave. So let's balance those, right? Intrinsic to the job and also extrinsic, unnecessary, the ones that, I don't want to call them never events. This is life, right? But there are some things that are much more manageable by systemic repair than by, doing a breathing exercise and drinking some, yogurt smoothie. The compassion costs that we're seeing now, especially with COVID, but it's always been in stressful healthcare environments, is a drain on the spirit. To some extent, and I don't want to carry this metaphor to an absurdity, but to some extent, when we're on shift, we are in a combat mindset. We're hyperstimulated, we're hyper alert. We're in a condition of contentiousness. It may be just the disease or the diagnosis or the time pressure or the fact that the patient's blood pressure is dropping. But this is a stress that is similar to being in combat. And when you look at combat fatigue in people who are in the military, you see all of the same physiological reactions that a nurse sees in ICU. If you don't replenish it, you get depleted. And again, I'm going to say this word injustice. These are the social injustices. All the things, look at the disparities that we see around us that can create discriminatory events or the sensation or perception of discrimination. And that is another combat-like stress. Many of the psychologists I used to train with said that the definition of depression is anger that it doesn't have an outlet. Bottled up anger. You've probably heard this. It's one of those mild truisms. But let's not leave it at that. I want to talk about some other extrinsic factors, and one of the most powerful, and also it's very unmentionable. This is politically incorrect and a little bit naughty to say, but compensation, provider compensation, healthcare, health plan, organization, hospital, pharmacy, you name it. Many years ago, like almost 40 years ago, I wrote a paper for the AAFP, which had to do with the principles of medical ethics, specifically from the primary care standpoint. And one of those principles that was adopted by the AAFP, I have no idea where it went now, is a recognition that we, as workers in organizations need money. Money is incredibly useful. It's a great invention. It's a tool, and we can't exist without it. So medicine supports itself by the means of commerce, whatever those are, be loose. But we don't adapt the values of commerce. For example, the one value of commerce is that the objective is maximizing revenue. And that is not anywhere in the medical ethic. But wait a minute, I just spoke falsely, because if you go to the medical staff meeting, or if you, one of the exercises that I have done with medical students and residents is that in the sort of medical business ethics course, I would have everybody get around the table and say, let's pretend we're the compensation committee for a big multi-specialty group. And what we're trying to do is we're just going to set next year's division of the revenue, right? Everybody will be assigned a certain salary. Let's pick what the salary variables are. And what we demonstrate when we take different roles and we play that game, using different models and different theories and algorithms for dividing up the money, what usually, if the class is smart and successful, which they usually are, they discover there is no way to do it. There is no equitable and universally satisfying formula for compensating healthcare providers. It can't be done. Here I have a burlesque of some of the phrases that you hear in the compensation committee. But the reason these are displayed is not because we can solve them, because you really can't. You negotiate them. But because this sentiment is subconsciously working as one of the sensory organs that detects injustice. Because once you violate a person's sense of self-worth or their sense of what they need financially, you create the same kind of injustice as if you are making fun of them because of sex or race or height or any other personal characteristic. And so this, when I'm going to pivot very soon toward talking about remedies, right? One of the remedies for dealing with the sense of financial injustice, and you have to laugh a little when you say, oh yeah, doctors experience financial injustice. Of course they can, but let's try to separate reality from perception. At any rate, this business of physician compensation has gone way back to 1700 BCE. The Code of Hammurabi has fee schedules built in it for doctors and other quality assurance systems. Remember, jumping forward a few thousand years, in the 1950s, we had usual and customary compensation. Then there was this thing, the RBRVS, and I'm going to put my pin in the map. This is the resource-based relative value study, the Shao study, very, very famous, published in the New England Journal, that impacted the consciousness of the healthcare system more than any other thing that I can think of. This is right up there with penicillin and germ theory in terms of how it defines the way physicians and patients and the payment system work together. And it is a stress. Reforming that, or improving it at least, would be one of the main remedies I can suggest for systemic stress. Here's something that's kind of interesting, a paper this is from Health Affairs. We built EHRs primarily, we adopted them through the HITECH Act, primarily in order to improve the efficiency of charge capture and the power of auditors to look at the appropriateness of claims. That's the reason why we have 98% EHR adoption today. The problem is that the actual tools inside of them, which we could discuss, another day, are not effective enough to actually measure the things that they're supposed to measure, which is how well are physicians working. This entire idea of value-based payment is predicated on the idea that we can measure value, and in fact, actually, our EHRs cannot. And so the sense of injustice that creates is, let me say, another stress. Here is the real oppressor. I mean, at least in my life, we all get to choose what's the thing that really hurts you the most. Here's the schedule. This is just a screenshot of someone's schedule, right? This is the oppressor. It is the schedule that is the boss. And it's a bad boss. It's a metaphorical boss. But it is the thing that drives not only, our day and makes it work, but it also drives a lot of the injury that we suffer during the day. And I mentioned that if you're going to quit your job, it's because of your boss. Think of the bosses that you work for. It may be a human being who is irritating. I've worked for some irritating people, but I also worked for some very nice people. So we don't all have a bad boss literally, but whoa, wait a minute. Here's another boss. This is the system that we're embedded in. This is an actual chart that somebody put together when they were voting in the Senate on the Affordable Care Act. And one of the senators turned to the little staff person, I don't know, some high school person, intern, and said, I'm not really clear about, what is the healthcare system? Could you just draw me a picture of that? And bango, there it is. Here's the picture. You can't read it, but it's a Senate staff person that did this. And my humorous challenge to you is, if there were an error in this, would you be able to spot it? So I'm not going to spend a lot of time on technology. My job is I'm a technology person. Atul Gawande points out that the system, meaning in this case the EHR, that was purchased and designed ostensibly to increase our mastery over work, has instead become our boss. Is it possible, I would challenge, and I'm only asking this rhetorically, that an entire industry could create a product that itself is inherently unsafe? And I have given some examples here of products that are just inherently unsafe. And I won't tell you my answer. I'll keep that quite secret. But I do ask the question, is the EHR a thing that has, at least inside of it, some embedded safety problems? And one of my arguments about that is here on this page. Is this helpful? Here's, and again, this is a screenshot of a made-up case, but is this the interface that I want to be looking at when I'm doing the humanistic job of easing suffering and pain and bringing health instead of disease? Well, some background behind this technology issue is that in some surveys, the EHR comes out as the leader in stresses that providers perceive. So I'm going to do an anthropomorphic analysis. This is a little unfair, but look, suppose the EHR were a person. Suppose you really did have an AI there that was your boss. It could be a superior, but it could be a peer. It could be your partner, your work partner, or it could be your assistant. It could be a subordinate. I would say that the EHR is a bad boss, a bad colleague, and a bad assistant for a lot of reasons. It has a lot of shortcomings that you wouldn't put up with in a human being. But that's not to say that they don't sometimes work. And there are good reviews for some aspects of some EHRs in some settings by some people. So I'm not going to say the glass is entirely empty. But I will say that the troublesome parts of these surveys where they say, no, does it improve efficiency? No. Well, that's an emergency. That's like saying, do you have the correct tools to do, spine surgery? If the surgeon says no, that isn't an inconvenience. That's a disaster. Here, just a picture of some of the things in the electronic ecosystem that I deal with from day to day that you can perceive as roadblocks to comfort, safety, and happiness. Well, I'm not going to dwell on this. I'm just going to throw up a couple of pictures, right? What have you brought to work with you from outside? What's clinging to you? What is stuck to the bottom of your shoe when you walk into the door at work? And it's externalities. It's what you saw on the news last night, or your kid's phone call, or the note you got, or something in the mail. And then, what are the toxic stressors that have nothing to do with patient care that you may have to do with at work? These are, again, also externalities that have nothing directly to do with the conduct of your behavior, but they absolutely impact your perception of comfort. Spirit burden is my word for this interruption problem. Like, oh no, like that person again on the schedule, anyone but them. Why does it have to be them? My first patient after lunch. Oh no. And the effect it has. Let me also throw up, while we're making a list, liability consciousness. And not everyone feels this the same way, but I work for a liability insurance company, and we absolutely do see physicians trapped in a malpractice claim who experience maximum stress, right up there with divorce and death in the family kind of stress, because of the guilt, shame, or feeling of injustice they're subjected to when their work is being scrutinized in a malpractice case. And when I say scrutinize, we are under scrutiny, of course, a lot. Performance measurement is the whole reason, remember, behind the HITECH Act and the EHR. That is the financing that paid for those things being put into everybody's hospital. There are over 2,500 performance measures that are available to be studied and adopted in the National Quality Measures Clearinghouse. It costs, someone says, $40,000 per physician per year. Look at this in your two-doctor practice, right? Who cares? $40,000 per physician in a giant system? That's nonsense. It doesn't matter. But in my own 3-doctor, 5-doctor, even 20-doctor practice, that's a big burden to comply with performance measures. And let me just insert, this is one of my most important points when I'm teaching in business school, which for heaven's sake, sometimes they let me do. This misquotation from W. Edwards Deming shows up everywhere. You hear, you can't manage what you can't measure. And that is exactly untrue, exactly the opposite of what Deming said. Here's his actual quote. I won't read it. We don't have time for this, but you can get this quote. You can look at it. I'll give you the slides, right? Some of the important points that Deming, who probably is one of the best analysts of business and management that has ever lived, points out that the principle of installing metrics on how people work is destructive of many of the goals of our organizations. And surveillance itself, not the particular metrics that could be unjust, unfair, or incredibly good and helpful. They could be both. But just the fact that we're being watched at every moment is another spirit burden. We know the EHR is watching us. If you just read this a report that came out last week about Microsoft Office, you realize that it is collecting an incredible amount of data on how you work every day in your office. If you use, a spreadsheet or a word processor or an email program or or even a communication chat program. Statistics about how that program is being used by you personally and your colleagues are deliverable to the administrators. That's been going on forever, but it's improving and getting more intrusive all the time. Plus, we have video surveillance. There are hospitals where there are cameras over the sinks so that we can time how well people are doing hand washing. Oh, well, it's just hand washing. But really, there are people who are being asked to observe others. There's geolocation. We know where you are, when you are. Anytime you interact with a system, your cell phone tells us where you were and how long you were there. We see this evidence sometimes in malpractice cases. Social media, oh, for heaven's sake, stay off of that if you're a healthcare person. And all of these kind of funnel down into maybe the worst spirit burden I know, which is the sense that you're on the clock. All right, so what? If you're suitably cheerful now, let me give you some remedies. I'm not going to leave you hanging here with, life is terrible, suck it up. We need multi-level therapy for this. When you break your leg, you need more than a cast. There's a whole psychosocial, economic rehab program, and that's what we need in healthcare, including this very important level that I want to emphasize is the supra-organizational level of the society, where we live in. Because a lot of what we do for society. So let me come down to the mockery. Okay, here it is. I'm famous for this. A lot of the resilience and burnout programs that I've seen promoted around the country kind of begin with the notion of let's toughen you up. Or, let's make you a better performing employee because I don't know, and we'll do it with coconut water or, exercise. I don't want to make myself an extremist by saying that personal resilience or, nutrition or going to bed on time, that those are meaningless. Far from it. Oh my goodness, yes, please do this. But this is not going to get you the job done. This will not do it. So here, I can make fun of that sort of stuff. You have a bunch of people who are in an absolutely toxic work environment, and you're coming by and you're offering them a way, to smooth it a little bit. That is wrong. Don't let your yoga guys get away from the session without saying, and by the way, who else needs yoga? The legislature that is installing another absurd requirement on you. Now, I don't want to go, this sort of is another cartoon. I don't want to go all the way to the Louis XVI solution, which is to throw the whole system out, burn it to the ground and start over. That isn't going to work. That never works. But I do have that sentiment, and I'm sympathetic to the idea of, what did Shakespeare say? Let's kill all the lawyers. What else have you got? Okay. But I like the sentiment, basically, quietly by myself. And if you want to talk to me offline about that, I'll say, yes, the lawyers must go. But here is a little bit more professional evidence that organizational remedies are by far the top-rated suggestion at a very smart, medical group. In Boston, they just asked their providers, where should we put our energy, for making life better? And the government ranked very low. They didn't think there was much the government could do. But the organization making the systems work better, the infrastructure stronger, and the management better, that was the answer. Individual, and regulatory, those came in, at a little more than half. And so that's where my head is at. Let me emphasize again, one of the downsides of the resilience theory making healthcare work better, by toughening up the practitioners. It really has a dark side to it, and that is the beginning to define anger as a disorder that needs to be managed. Anger itself is not even a diagnosis, according to the DSM-5, which is, of course, the grand authority of all diagnoses. Aggression, irritability, anger as a symptom show up in a lot of the diagnoses. There is proposed for the next version of the DSM, temper dysregulation disorder with dysphoria. Woohoo! That's when the doctor throws the syringe against the wall, right? They're throwing instruments in the OR. Okay, but that's a symptom. Let us not define that as a disease that we want to treat, with yoga or, alcohol or vodka, whatever it is your treatment is. Don't think of this as the disease. I don't have time to go into drapetomania, but make a little star by that and then look it up on the internet if you want to see how the definition of a disease can change over history. I like to look at anger, and I'm calling out anger because that's one of the most important symptoms we have about burnout. I want to look at it not as a personal disorder and a failing and a weakness. Instead, it may be an appropriate response to injustice. When you see anger in a 4-year-old, one of your first questions should be, is someone treating you unfairly? How do you perceive that? They may be right or wrong, but the anger is usually a response to a stimulus. Let's go analyze the stimulus. There's some therapies about anger, anger management, that want to fix anger by getting you more functional and back to work, just like the soldier, put a Band-Aid on it and, get back in line. I'm going to make maybe a bold statement that it is not ethical to offer therapy, anger reduction therapy for justifiable anger. And that's a hard thing to say in organizations where anger is destructive. You don't want to work around an angry person. You don't want to be the angry person. But please, let's look at this like you would look at bleeding. It isn't that you want to stop the bleeding. You want to diagnose it. So let's adjust the workflow, right? There's things we can do with technology. I love technology, right? So I'll put that at the top. Reducing cognitive load. Controlling tempo. I think that is absolutely the first thing that we need to look at in terms of workplace improvement. Reducing manual load as well as cognitive load, getting help in, staffing adequately. Work hours, increase idleness. Oh, that's a terrible thing. I am actually a manager person who says increase idleness, and I'll tell you why in just a section. I really think we need to dump the RBRBS. We need to relook at so-called value-based purchasing because we can't measure value very well. We need to look at piecework, pay for performance, and all of the compensations, because those are a major underlying source of the perception of injustice. And, talking more. Here's Hippocrates, right? Go through the problem list that we just went through. Like I listed maybe 900 problems, and go through those and figure out if each of them were a disease or a manifestation. What would you do as a doctor, a doctory person, to address those in a humanistic way? Competence, right? Starting at the top of your managerial system. It's critical. Your own and the people you work around. I'm going to hit equity and fairness again. It's highly perceived as one of the main stress sources. Give people a voice. Make your goals and metrics reasonable, and trust me, if you look at them, many are not. Compensation, you got to do that responsibly, and it is not. Tempo, I mentioned that. The slower doctor is the better doctor, many times. That's not true for all things, but in cognitive areas, it certainly is. Reduce the feeling of jeopardy. Reduce the feeling of toxicity. Do not design a system for efficiency. Efficiency is weighed against safety and fragility. If you look at fault tolerance in systems, when you push the envelope of efficiency up to like 100%, what you're trading off against is the ability of the system to deal with stresses. So allow 80%, 70%, I don't know what's ideal in your organization. Allow reduced efficiency in favor of safety and effectiveness. In the martial arts and military worlds, we say slow is smooth and smooth is fast. It may take a little bit to understand that, but think of that mantra. Also think that we are air-breathing mammals. Right now, here we're getting a little bit poetic, but bear with me one slide. The dolphin and the weightlifter have this in common. They have to hold their breath while they're doing their work, but they can only hold their breath for a certain length of time. And then they have to interrupt. Then they have to exhale. They have to get the toxins out. Then they have to inhale again. They have to replenish. We work in cycles. You cannot decide that you're going to hold your breath for a 12-hour shift. You can't say that I'm going to exert maximum effort for a 12-hour sustained shift or even a 1-hour sustained CPR event without being able to then surface. Take a breath, do nothing, cleanse it. And that's this theory of cycling. We work in environments where there are cycles, and we need to build into those cycles the ability, like any muscle, it tenses and it relaxes. We have to plan in our systems for periodic cycles of exertion and relaxation. And it's amazing how many managerial systems don't do that. They are designed for sustained maximal effort. Okay, I'm just about done here. Okay, so I'll end with this cute one. Here we have one of the most creative remedies that I've seen. This is against the interrupt-driven problem, where this is an actual picture of an emergency room in Denver, where this very brilliant doctor created a signal for the nurses that says, we're running the board right now. If you interrupt this, we're going to, be upset. I won't use any of the other phrases. They're inappropriate. But don't bother us now is what this signal indicates. And this actually is a stress reducer and one of the tiny steps toward burnout reduction. Okay, I think I'm okay as far as time. You guys need to tell me. Those are my contact things. You get the slides. Remember that. I'm going to stop sharing, right, and then we can talk. There. Okay. Should be done.
If anyone has questions, please type them into the question box.
I'll trust you to read them. I don't know if I am able to see everything.
Okay, I see one question. Med schools are too expensive and have too much unnecessary requirements. This has to be changed so that young people can apply.
Oh, wonderful. I'm going to say that that's true of higher education in general. And, that's an opportunity for me to soapbox this whole thing, which I'm going to pass on because I have many thoughts and theories. I'm actually involved in finance discussions at the college level, not the med school level. It's just too much for me. I won't go there. But yes, okay. But of course, every element of that statement, med schools are too expensive. They should be more affordable. and they have too many requirements. I'm not sure, those are really two problems. I don't think the expense is necessarily linked to the educational curriculum requirements. What we do know is that whatever they teach in medical school, it's not enough. And I will vouch, dealing with many medical students that I see weekly, that they don't nearly know enough. And that's why we have residency, right? But I don't think that's linked directly to the expense. I think the expense is another problem, and that has much more to do with the expectations of the infrastructure that we need to build around higher education. I might say that the expense of training an Air Force cadet at the Air Force Academy to fly jets is way, way too expensive, and the expense of a naval officer of learning to drive an aircraft carrier, that's way, way too much. But I'm not competent to make that judgment. I do know that running a medical school is a mixed bag between expenses that are absolutely necessary and very much more than college, and expenses that are silly. They're padding and they're unjust and absurd. This also is true at the college level, where I think the ratio of what you pay to what you get is much worse even than in medical school. But that's a long-winded way of saying, yeah, you're right.
Okay, next question. Have you found certain types of leadership impact burnout more than other types?
Oh, my goodness, yes. There are profiles, scoring systems and taxonomies of different leadership styles. And of course, this is absurd but true. The go-it-alone, hierarchical, paternalistic, and I use that word without sexist intent, a style of that we used to look for and select for among physicians exactly makes them unsuitable to be managers in general. So the more you go up the level of physician leadership, the more you're likely to see that many of the traits that made you possibly a good physician can make you a very weak manager. And so pivoting the medical management team from one form of ethic to another, or one character trait to another, that's really critical. But also the non-physician manager of physicians can have equally unbalanced character traits. And all the things about dictatorial, non-listening, remote, insensitive, hierarchical, belligerent, bullying, dominating, infantile, selfish, juvenile, or psychopathic leader. Unfortunately, a lot of those really negative character traits are selected for, sought by, and brought to interviews by candidates, and we choose those character traits, and that's our fault.
And a comment, healthcare workers should be treated as professional, not just labor. Healthcare workers are more compassion-oriented rather than money-oriented.
I wish that were true universally. It certainly is true. You can actually show a decay curve. If you take incoming health profession students, medical, nursing, pharmacy, I don't care who you are, physical therapy, the altruism scores tend to be very high, or at least the portrayal of the candidate as altruistic is very heavily weighted, and then it deteriorates throughout the course of a career. And not a straight line, it goes up and down. But we have to be careful to generalize. We are professionals. Let's be a little clear about what a professional means. My definition of a professional is a worker who has the obligation and skill to manage conflicts of interest. You can just be an assembly line worker, and your interest is make money, make widgets, go home. But as a professional, you're raised to another level. And what that level is that you're going to deal with very, very serious conflicts of interest. People dying, people crying, not enough resources, long hours, fatigue, stress, unfairness. And that's the personal resilience bit, that the covenant you have with society for giving you this package of wonderful privileges that you have as a professional, the license you have to say, call me doctor. That's serious. I have very special privileges. Well, the coin that you buy those privileges with is your ability to manage conflicts of interest, internally and externally. So yeah, that is true, and we should be treated as those kinds of people. Yes, the employment model for physicians, which I happen to like very, very much, it does have the risk of depersonalizing workers. That's the employment model of anything. But managing that is the task of the organization.
That's all the questions that have appeared. Oh, one more. In socialized medicine, the doctors are in control of healthcare. They're the ones who make the decisions. Oh, that's a comment. With socialized medicine, the doctors are in control and they make the decision. Yep, that's it.
Okay. Well, that's a good debate point. I would say, defend or refute this statement, and there would be a good debate on both sides. I don't know what socialized medicine is. I have worked in countries where there is socialized medicine. I worked in Britain very briefly, as a doctor, and I can tell you that they would say, yeah, we have socialized medicine here. And I can tell you that the decisions are not made by doctors, or not at all in the way that the United States thinks of doctors making decisions. We don't have, in the most capitalist of systems, think of, our largest integrated delivery systems in the U.S., they function like socialized medicine within the delivery system, but the decision makers are not doctors, at least not entirely. And in the socialized systems like Germany or Belgium, where I have some familiarity, Netherlands, England, no, it's not doctors making those decisions. And when they are, they're not functioning as doctors. They're not operating off of the medical ethic. They're operating off of a social welfare ethic that is also very good, very necessary. I subscribe to it. I like the idea that we should all take care of the people that are injured and hurt in our system. But it's not the same calculus as the caregiving medical ethic at the point of care. So I'm very suspicious of doctor managers. I've been one, and I can tell you that the interests that you have to balance are completely different from the interests in your examining room. So we would have to talk about now, okay, what is a doctor?
And the last comment is, thank you.
Oh, yeah, good one. Thank you, too. All right. I'll come back. You guys want to talk about something else? I'm happy to do it.
All right. Thank you very much.